This is a patient that, you can see this how narrow is the mandible. Run here. See how much crowding we have. So if I can compare these, and you know what? The good thing, Ron, less and less clinicians, they are removing teeth. We rather, not slenderizing, meaning that, shaving the teeth in the lower one to correct this. So this is a patient. And just to familiarize the audience, AHI, apnea hypopnea index, the number of times that they completely stop breathing or partially stop breathing, index per hour. 5, they say that is mild sleep apnea. Under 5 is normal. 16 to 30 is moderate. Above that is severe. This patient overall 46.9. On his back, it is 70. This is a super severe sleep apnea.
Wow.
How do you want to leave this patient with not breathing during this period of time? So that's what we gave him, the appliance, so he can breathe. Now we did the distraction of the mandible, expanded the lower arch, and then when we go here, I show you. So look at this run. The anterior part of the mandible, how much expanded, which is about 10 millimeter we expanded, and the teeth gradually, they are going to move to each other even with no braces. This is the beautiful part of it. The same on top or bottom. His sleep apnea was so severe that we decided to do the lower one first, then upper one, because if he added upper expander and lower expander, the ApnoTX could not support it. He did the lower expansion, and his sleep apnea, remember that was 46 something on his back, 70 run, dropped to 21.
Wow.
Almost made the sleep apnea severity half. And then when he was wearing the ApnoTX at the same time, so when he had the sleep test with no ApnoTX, his severity dropped to 21 from 46. When he was wearing the ApnoTX, the severity completely under 5 is 2.4, managed very well.
Doctor,
So,
why does expanding the mandible improve sleep apnea? Does it give tongue space? Is it pulling soft tissues out of the airway? What's happening there?
okay, Ron, you are the one you are going to, know better than me. So let's review what you said during that lecture.
Okay.
So let's review what are the things that you said.
Okay.
Let's start. Okay, we expand the mandible. The platysma, which is the muscle that is going to be under the tongue, is going to be lifted up. When we expand the mandible like this, the platysma is here, is going to be lifted up, and that is going to bring the tongue up and forward. The hyoid bone, because of ligaments that are attached to it, is going to be lifted up. The tongue space, because the bone is going to be expanded, tongue is going to have more space. All right. And then from the stability, when we expand the bone, the raphe, that is the area that the buccinator muscle, which is here, is attached to it, is going to be away, so it doesn't push the teeth forward.
So
it's a significant number of things that it caused the airway not only be stable, more stable, and reduce it, and but also the final stability of the teeth is better than SFOT.
Right.
SFOT, we are running the teeth into the buccinator muscles, but this, does not.
So really, doctor, you're a really nice guy because you let the other doctors off easy when you say, no, they match the lower teeth to the upper after MSE with SFOT. It's really not equal. SFOT is not equal to mandibular skeletal expansion at all. One is frosting and one is cake.
So the patient is going to be back on the Invisalign. Now the spaces are closing and run. When we did this maxilla, when we did the MSE and we did the lower expansion, look at this, 46 dropped to 11.2. All right. What is the next? So we did a stage 1 dame in the mandibular expansion. It is a stage 1 telegenetic, dropped it to from 46 to 21. And then when Dr. Bobak did the maxillary MSE, dropped it to 11.2. And guess what? What is the next stage of telegenetic? who is going to do the next stage of telegenetic? Because this patient was candidate for MMA surgery, but doesn't want to go through the MMA surgery. And when we dropped it to 11.2, really I cannot justify to send the patient, although his RDI still is 19.6, but his AHI is so manageable that he can continue wearing the Apno TX lifetime, right, for management. Or the next clinician that come in is ENT that is going to do turbinoplasty as another paradigm shift. ENT comes and do the turbinoplasty as another telegenetic stage of treatment. And she did it. We are just waiting for the sleep test, see that how the patient respond to this.
What do you
And
think,
maybe
doctor,
we
about, and I totally get it. That makes sense. Removing obstructions in the nose is the next step. But what do you say to people who fear empty nose syndrome? Have you seen a lot of
yes.
empty nose syndrome?
I haven't seen it by myself yet. I heard about it. And usually the turbinoplasty is, especially these days, is sucking the juice or fluid out of the turbinates. It can come back and it can regrow back, but at the same time is an effective procedure. And I consider it is telegenetic surgery.